Okay, here is attempt 2 for this sequencing lecture. This was the other one that got deleted off my YouTube account. Alright, so in terms of this class, I'm not really technically doing an introduction to coding, I guess. It's more to the new system, so I'm hoping most of you have a base knowledge in coding, but I do want to talk about some of the sequencing guidelines and some of the other ones that aren't caught really in the conventions that we talked about already or in the chapter-specific guidelines. So this really is kind of the last section of the CMS guidelines. So our guidelines reference the Uniform Hospital Discharge Data Set and the Uniform Ambulatory Care Data Set. So these are both uniform data sets that are used. We have uniform definitions and things like that so that we can compare data across facilities. So the UHDDS has the principal diagnosis and principal procedure, and then the UACDS has the first listed diagnosis. So we're going to talk about all of these definitions. So first we'll look at inpatient guidelines. There are a few things that are different between inpatient and outpatient. So inpatient, there's a few differences in terms of principal diagnosis, what you can code and cannot code. And then also, this doesn't really fall into sequencing, but a big difference with ICD-10 in general is, or not necessarily a difference, but just something to make note of, is ICD-10 PCS is technically only required for hospital inpatient. I've had some people ask me if it's going to replace CPT. The answer there is no. CPT will still be used for outpatient and for physician services. So the PCS, I think it's very important to understand the system. If you ever want to get into inpatient coding, technically it is only mandatory for hospital inpatient coding. Now, if hospitals choose to use it for outpatient procedures for statistical purposes, that remains to be seen. I know that ICD-10 or ICD-9, excuse me, is used that way a lot currently. With the massive changes in ICD-10 PCS, I don't know if that'll stay or not. Okay, principal diagnosis. This is a huge part of coding, and I still remember this exact definition from when I was in school. So let's read the definition and then kind of break it down. So this is our diagnosis that is sequenced first, and it is the condition established after study to be chiefly responsible for occasioning the admission of the patient to the hospital for care. So you can see that things are going to depend on the circumstances of admission, but I do want to talk about some key words in here. So one, it's a condition, so we know it's some sort of diagnosis or condition. After study, so established after study. So we talked a little bit about signs and symptoms and how if we have a more definitive condition, that's what we're going to be coding. So let's say we had that patient come in with the right lower quadrant pain and the nausea, maybe vomiting. Well, after study, we determine that that's acute appendicitis. So that's our key here for after study, is that we're going to report the most definitive condition that we have documented rather than just the signs and symptoms that led us there. And then the part chiefly responsible for occasioning the admission of the patient to the hospital for care. So remember, when we talk about principal diagnosis, we're talking about hospital inpatient. So we're looking for that key thing that made them be admitted. So let's say we had that acute appendicitis patient and it was severe enough a case that they're going to admit them to the hospital. So that acute appendicitis is why they were admitted to the hospital after study, right? So they came to the hospital because they had pain and nausea, but then they really were admitted for this more definitive diagnosis of acute appendicitis. All right, now of course there's always kind of little things that come up, so here's some different questions we might have. So what if the diagnostic statement includes symptoms, signs, and ill-defined conditions? Well, again, if we have a definitive diagnosis that's been established, that's what we're going to be coding, not the signs and symptoms. What if we have two or more diagnoses that meet the definition? So let's say maybe we have a patient that's in respiratory distress and has a exacerbation of COPD or something like that. I don't know. And they're documented separately. If two diagnoses meet the definition, so both of them were really equally important in admission of the patient to the hospital for care, it doesn't matter which one's sequenced first, unless the codebook in some way indicates otherwise. What if the physician mentions 2 or more comparative or contrasting conditions? So maybe they list pneumonia or bronchitis. Well, for inpatient, we are actually going to code both as though they are confirmed. And kind of the logic here, so let's say a patient is admitted and their discharge diagnosis is pneumonia or bronchitis. Essentially what they've done really is a workup and treatment for both pneumonia and bronchitis. So we're going to go ahead and code both of those. Now, sometimes you'll have a diagnostic statement that includes a symptom followed by comparative or contrasting diagnoses. So let's say we have hemoptysis, pneumonia or bronchitis. In that case, we're actually going to code all 3. So I know this kind of seems like it goes a little bit against our signs and symptoms rule, but this is just one of those guidelines. So in that case, we would code the hemoptysis, the pneumonia, and the bronchitis, and we actually would keep it in that sequence, and the symptom is sequenced first. So just kind of one of those quirky rules. What if the original treatment plan is not carried out? So let's say a patient comes in for, I don't know, a stent placement because they have coronary artery disease, and then for some reason they can't place a stent. It's too complicated, or the patient has, their blood pressure shoots up, or something like that. Our principal diagnosis is still the same. They came in to treat the coronary artery disease. That is still our principal diagnosis. So if a patient comes in for complications of surgery, then that complication code is going to be first. Here's another inpatient only rule. So what if the physician's uncertain? So sometimes they'll say like rule out myocardial infarction or probable pneumonia or suspected infection or something like that. For inpatient only, we code as confirmed. Okay, so rule out myocardial infarction, we code an MI. Probable pneumonia, we code pneumonia. Suspected infection, we code the infection. That's an inpatient only rule. Again, here kind of the logic is that if we're admitting them to rule out an MI, we're probably going to do the full workup and treat the patient as though they have an MI until we can actually confirm that it is not an MI. So the one that you have to watch out for is this ruled out. So if it says maybe on the admitting documentation rule out MI, but then on the discharge summary it states MI ruled out, I can't code an MI. All I can do is code any of those signs and symptoms or any other definitive conditions that that led us to believe that it might be an MI. Okay, so hospital inpatient only, we code any sort of suspected or unconfirmed condition as confirmed unless it specifically states ruled out. Then we can't code those. Sorry, my phone. Alright, so admission following other hospital care. What if a patient's admitted following medical observation? Again, we're going to go with whatever condition actually led to the hospital admission. Same with the patient that's admitted following post-op observation or outpatient surgery. If it's a complication, and that's why they're admitted, that's what we're going to code. If it's the same reason as the outpatient surgery, if it's unrelated condition, again, keep going back to that principal diagnosis definition, chiefly responsible for occasioning their admission to the hospital. So besides our principal diagnosis, we do have additional diagnoses, and these are also required by the UHDDS. Here's our definition: all conditions that coexist at the time of the admission, that develop subsequently, or that affect the treatment received and or the length of stay. Diagnoses that relate to an earlier episode which have no bearing on the current hospital stay are to be excluded. So if we have an additional diagnosis that requires additional clinical evaluation or affects clinical evaluation, requires additional treatment, requires additional diagnostic tests, extends their length of stay, or requires increased nursing care, we're going to code that as well. So a lot of your chronic conditions are pretty common, commonly need to be coded, so like diabetes, hypertension, malignant neoplasm, something like that. Those are going to need to be coded. Now, if you have something that has absolutely no bearing on the current stay, so maybe the patient is allergic to peanuts, but they're being admitted for appendicitis or something like that. Well, we probably don't really care that they're allergic to peanuts, right? So we don't need to worry about coding that. Or let's say in terms of, you can also code like a history of an appendectomy. Let's say a patient's in for some sort of diabetes complication, and they had their tonsils out and had tonsillitis when they were 3. Probably doesn't really matter, right? If they're, let's say they're coming in when they're 58 years old for a diabetic complication. So it has to have some sort of bearing on the current stay. So again, in terms of any sort of previous conditions or history, if it has some sort of impact. So like if the patient's coming in with a lump in their breast and they have a family history of breast cancer, that's probably something important to note. Abnormal findings, you don't need to worry about those unless the physician indicates they're significant. So you'll see these a lot, especially on like a standard chest x-ray. If you have a patient that's 80 years old, chances are they're probably going to have some degeneration of the spine. That's a really common finding unless a physician notes it either as a concern, if they run more diagnostic tests on it, or they indicate some sort of follow-up care. You don't need to worry about those. And uncertain diagnoses, for inpatient only, it's the same guidelines. We go ahead and code those as confirmed. All right, outpatient guidelines, a little bit different. One, we don't technically call it a principal diagnosis, also, although I have kind of a bad habit of doing that. It's technically your first listed diagnosis, and the main reason here is it's a slightly different definition. So this is the diagnostic condition, problem, or other reason for encounter or visit documented in the patient record to be chiefly responsible for the services provided. So notice here we don't really have an after-study component, and we don't have the admission to the hospital component. So, and here, just typically, a lot of times you don't have the time to do the after-study piece, so signs and symptoms are pretty common. If they're coming in for outpatient surgery, you want to code the reason they're there for the surgery. They're coming in for observation, etc. So again, signs and symptoms are acceptable if you don't have a more definitive diagnosis. If you do, so let's say it's the acute appendicitis patient, they could easily be an outpatient. It's still going to be the acute appendicitis that we're going to code, not the right lower quadrant pain and nausea. You do get a lot more of your Z codes in outpatient. Here's something different for outpatient. So what we're calling qualified diagnoses, or any of those uncertain, the suspected, questionable. For outpatient, we do not code those. Again, logic here is that we did not probably do a full workup for those because the patient wasn't there for that long. So instead, we're going to code whatever signs or symptoms are making us suspect pneumonia. So if it's coughing, fever, whatever those are, we're going to code those instead. In terms of reporting chronic diseases, it's the same kind of guidelines. So even if a patient's in for acute appendicitis, diabetes can still be a factor, especially in terms of treatment and healing time. So we still want to code those in addition to the acute appendicitis. Same thing with coexisting conditions. If they're coming in for like therapeutic services, we'll talk about chemotherapy when we look at Chapter 2. That's actually going to be your principal diagnosis if they're coming in just for chemo. If they're coming in for pre-op, then that's your principal, and then you have, first listed, and then you have your reason for surgery. If they are coming in for surgery, typically your post-op diagnosis, so what usually appears on your op report, it's typically going to be more definitive. So that's usually where I go to get that. So if that definitive diagnosis captures any of the signs and symptoms that led them there, you don't need to worry about coding the signs and symptoms separately.